Ladies and gentlemen, we'd like to thank Dr. Seth, who will be joining us for the next leg of the presentations in a couple of sessions later on. We now request Colonel Parashar and Dr. Sarita Gulati to please stay on, as they would be chairing the WCCPCI 2012 BK Rajyogini Dadi Janki oration, and I would request Professor Vijay Lakshmi to please join the chairpersons on the dais, and may I request Colonel Parashar to kindly introduce the person on whose name the oration is and Dr. Chopra to this august audience. He'll have 15 minutes followed by 3 minutes for the oration formalities. Being an oration, we will not have any questions from the floor. Colonel Parashar.
Dadi has been sort of introduced several times, one of the chief persons of this organization, and in her own honor this was given, this oration. Now Dr. Vijay Lakshmi is here, and I'll ask her to put the medal, to do a Jaimal on K Chopra with the medal. Dr. Gulati, please come. Since morning, Dr. Chopra has been introduced several times, so he need not get any introduction, I think.
Chairman, Madam, Chairman, Sirs, fellow colleagues, ladies and gentlemen. We just heard on the TV evaluation by echocardiography, especially transesophageal echo, and a very nice point raised by OP. My subject is very different because we see a lot of metabolic syndrome in India, and we really intervene by our medical evaluation as well as by echo evaluation and medical evaluation by statins in these patients. And of course, those who become really organic, we go for even ECP intervention. My main agenda of presentation is to highlight on HFnEF, heart failure, normal ejection fraction. Most of them are labeled as depression or psychic patients. In fact, they are suffering from HFnEF. We need to evaluate these patients. Why, where and when to recommend 3D echo is very, very important, because we want to know the diagnostic, prognostic and therapeutic implications, and we wish to evaluate various echo variables like LV MPI, myocardial performance index, LV diastolic dysfunction, and left atrial volume index, which is very important. Left ventricular filling pressures by TDI is a very, very important variable which we can detect in patients who are occult and undetected HFnEF. Left ventricular mass index, concentric left ventricular remodeling, and LV ejection fraction. HFnEF, as I mentioned to you, the 5-year mortality rate in heart failure in men is 60% and 45% in women. In HFnEF, 40 to 55% of patients come with the heart failure, those who are having a heart failure. This data is known to all of us in the heart study, and I think I will mention to you the most common determinants of this particular data is high levels of lipids, hypertension and central obesity. I'd just like to have a case presentation. A 58-year-old female who was labeled as psychotic patient, hypertensive, mildly diabetic, was treated by a psychiatrist, came to our emergency with shortness of breath, tightness in chest, orthopnea with a pinky and frothy sputum. When she came in the emergency, the blood pressure was 200 by 110. She was not on any antihypertensive medication. Lungs bilateral collapse, EKG revealed LVH, IVS, and X-ray chest revealed pulmonary edema. Creatinine level were marginally high, BNP was high, and TROP-I was negative. The bedside echo revealed LVH, LV mass index was high, left atrial volume were high, and grade 2 LV diastolic dysfunction with E by E prime ratio of more than 20, suggesting increased LV filling pressures and LV and diastolic pressure with normal LV ejection fraction. This is we're seeing across the mitral valve, across the pulmonic valve, we see the concentric LVH, across the TDI, we are seeing across mitral valve the E by E prime ratio is 18.9 in this case. Significant LVH by 3D echo. What's the diagnosis here? The diagnosis is HFnF in metabolic syndrome. How to evaluate HFnF by 3D echo is the main thing which I really like all of us to understand. There are various methods: conventional Doppler, TDI, 3D echo, 3D echo speckle tracking, strain and strain rate, LV torsion, and LS stiffness index recently. 3D echo, as I mentioned to you, our data published in Indian Heart Journal somewhere in 2009 of a limited number of patients. And we have shown that 3D echo is the most powerful predictor of occult heart failure. This is just to show that our patients, there are 100 in number, and we have taken only those patients who were diagnosed as a cases of metabolic syndrome with NCEP ATP3 criteria. They were both IPD and OPD, and they were subjected to LV-MPI, LAVI evaluation, LV mass index, LV diastolic dysfunction, and DPDT evaluation. Similarly, various other variables were also considered. This is how they were statistically analyzed. And we evaluated various variables that I mentioned to you, and we wanted to know which is the most sensitive echo variable in the masked HFnF. As we mentioned to you, LV-MPI more than 0.4 is abnormal, and we divided our patient to 3 groups: less than 40, 40 to 60, and above 60. And we found as the patient grew beyond 60, the LV-MPI levels were very, very high. This is how we measure the LV-MPI. As I mentioned to you, the highest number of patients who had increased LV-MPI was 40 to 60 of metabolic syndrome. We divided our patient based on the LV-MPI into 3 groups. Group 1, 0.4 to 0.6, Group 2, 0.6 to 0.8, and those who are Group 3, they are more than 0.81. So ladies and gentlemen, the conclusion was that LV-MPI is most robust as compared to LAVI for detection of mild to moderate LV diastolic dysfunction. This is the data which we have published, that HFnF can also show a very significant reduction of LV-MPI by EECP. This data has been published in the Heart Protection book as well as in the Indian Heart Journal. This is just to show the LV-MPI before and after ECP, a very powerful reduction of a statistical power of 0.001. LV diastolic dysfunction also has been shown very significantly high in Group C as compared to Group B. This is just to show the inverse relationship of E by A ratio upon E by E prime ratio in our series of patients. Here we are seeing the HFnF relationship and the EA reversal we see after post ECP. HFnF showed a very significant reduction in the E by E prime ratio after 35 cycles of ECP. LAVI, Dr. Parashar speaks many times in the echo meetings on LAVI. I think LAVI is a critical determinant of LA dimensions. As you know, that LA is not symmetrical 3D structure. Its size varies with the body surface area. It expresses the LV filling pressures, and it is a predictor of LA remodeling. It predicts atrial fibrillation. It predicts LA stasis and thrombus formation and thromboembolic episodes. This is how we measure the LA remodeling. And we all know when the LAVI is more than 32 ml per square meter is abnormal. And it shows the increased vulnerability to atrial fibrillation, and the prognosis or morbidity is mortality is accordingly assessable. LAVI is a very, very powerful predictor of survival, and we show here that the morbidity and mortality is very high when the LAVI is more than 32 ml per square meter. This is how we measure the 3D echo of LAV dimensions. There is a direct relationship between the LAVI and the degree of LV diastolic dysfunction. This is just to show a significant change pre-ECP and post-ECP in the patient, because most of them had grade 3 to grade 4 LV diastolic dysfunction. LAVI does not change when there is a grade 1 or grade 2 diastolic dysfunction. So ladies and gentlemen, the message is very clear that LAVI is highly robust for grade 3 and grade 4 LV diastolic dysfunction, but is less robust for grade 1 and grade 2 diastolic dysfunction. LV mass index, as I mentioned to you, We subjected all our patients for evaluation of concentric LVH, eccentric LVH and concentric LV remodeling. And we find here, we measured the LV index by all the methods, by body surface area, by height as well as by BMI. And we find the concentric LV remodeling where the relative wall thickness increase while the LV mass index is normal has a good outcome as compared to concentric LVH and eccentric LVH where there is a poor outcome with the increase in the mass index. So mass index has a poor prognosis, rise of the mass index. Concentric LV remodeling significantly change with ECP. It is reversible. And E by E prime ratio significantly change after we subject our patient to ECP. Pattern of LVH pre and post ECP does not change. It is only the remodeling which change, but not the hypertrophy. So ladies and gentlemen, we have a limited data with no controls. It's an observational study. There is no angiographic correlation. Most of our patients are on drugs like antiplatelets, statins and ACE inhibitors, and limited number of patients. HFnF risk stratification is very, very important, whether it's metabolic syndrome or diabetes or hypertension, remodeling or hypertrophy. What is the most common cause? What leads to HFnF? The slide is stuck. Excuse me. Yeah. The most common cause is metabolic syndrome. Second is metabolic syndrome. Third is metabolic syndrome. What's the message? Any obese patient come to you in your OPD with some psychosomatic symptoms, please do not label them as psychiatric patients. They may have breathlessness as a cause because of manifestation of HFnF, and we underestimate it. This is just to show the relationship of LV filling pressures and E by E prime ratio. New modalities are strain and strain rate. I won't go to the details. In strain and strain rate significantly reduce both of LA in patient with the HFnF. This is just to show that 2D strain speckle tracking is angle independent. Stuck again. LV torsion at base and apex significantly vary in the patient with HFnF. Recently there is an article on LA stiffness. We don't have any experience of evaluating LA stiffness. It says that LA stiffness index is of a great higher sensitivity and predictability, and it is of a great value and has got an inverse of compliance to predict the LV diastolic dysfunction in HFnF. To conclude, ladies and gentlemen, 3D echo is the most powerful predictor of occult HFnF. Conventional Doppler across mitral inflow tract and pulmonary valve has a tremendous clinical implication. TDI across the mitral annulus is highly sensitive, specific for predicting LA, LV and LA filling pressures. 3D echo variables has a tremendous clinical implication for diagnostic, prognostic and therapeutic implication, and neuroimaging modalities need further validation like LA ejection fraction or LA stiffness. So what's the take-home message? The take-home message is health of millions is at stake in India with HFnF suffering from metabolic syndrome. We should not underestimate it. Periodic 3D echo evaluation of a occult HFnF is a must if we really want to reverse the HFnF. TDI, 3D echo, strain imaging are promising tools for evaluation of HFnF and may predict therapeutic response. Strain and strain rate may be promising in early detection of occult HFnF. LA stiffness index and LA ejection fraction are new modalities. They need more validation, more studies and more data. LV torsion in transmission from experimental to clinical validation for HFnF in metabolic syndrome. Here is a guy who is suffering from HFnF, very obese. He is sitting on a chair. Since he is not able to do a treadmill, he is making his dog to do a treadmill. Thank you very much for your patient hearing.
Thank you very much, Dr. Chopra. As usual, it was fascinating and very lucid presentation. And please give him a big hand for a presentation.
Ladies and gentlemen, that brings us to the end of the WCCPCI 2012 BK Rajyogini Dadi Janki oration. We'd like to thank all the chairpersons and Dr. Chopra.